Good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus of today's session is role of radiotherapy in cancer cervix. So before we starting the session, I would like to lighting the lamp and play Ganesh Vandana to give a warm welcome to each and everyone present in this webinar.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you so much everyone for your patience. So let's begin to this session, for which I would like to invite Dr. Diksha Chaturvedi ma'am to take over. Ma'am, please proceed with the talk.
Good evening, everyone. It's a great pleasure to welcome you all to this webinar on treatment of cancer cervix, all stages. Today, we bring together some of the brightest minds in oncology to delve into the latest advancements, strategies, and challenges in the treatment of this prevalent yet highly treatable cancer. This session is designed to provide a comprehensive understanding of cancer cervix management, covering every stage of the disease, from early stage surgical interventions to advanced radiotherapy and systemic therapies. Today, we have two brilliant speakers, Dr. Sankalp Naidu sir and Dr. Sahana Punashetty ma'am, to cover the topics. And we have a panel of fully qualified and experienced professionals to add to their topics respectively, with comments and experiences and knowledgeable skills. We hope that this webinar fosters insightful discussions, enhances knowledge, and inspires all participants to contribute more effectively to improving patients' outcomes. Let's get started with this session and welcome once again all the dignitaries, speakers, and participants. Now I hand over the virtual mic, to Dr. A.K. Chaturvedi, senior oncologist, Dr. Chaturvedi Cancer Hospital, Gorakhpur, to conduct the further session.
Thank you, Dr. Diksha. Am I audible?
Yes, sir, you're audible.
Okay, fine. So today we are here to discuss about the management of cancer cervix by radiotherapy and surgery. As you know, the cancer cervix is fourth common cancer in women worldwide, with a significant burden in low and middle income countries, and the human papilloma virus is the leading cause, particularly 16 and 18. Apart from other contributing factors, poor socioeconomic status, poor nutrition, and not having proper hygiene, multiparity, polygamy, and so on and so forth. So, since HPV infection leads to genetic mutation in the cervical cells, progressing to the precancerous lesion, and that later on changes to invasive carcinomas. So we have to check this particular thing. We have to do early detection of the cancer so that the outcome of the cancer cervix, this is the type of preventable cancer which we can prevent very easily, and if it happens, it can be treated in early stage and we can get cured. So there are three modalities that you know: surgery, radiotherapy, and chemotherapy, immunotherapy, and so on. So today, under the aegis of Onco Integrated Foundation, we have arranged this particular talk. And first topic is on radiotherapy, management of cancer cervix, stage-wise by the radiotherapy. And we have got certain renowned experts in this field. Dr. Ayush Garg, MBBS from Muzaffarnagar, MD from SRMS Bareilly. His area of interest is head and neck cancer, gynecological malignancies, breast cancer, brain, and he is right now associate professor in SRMS. Dr. Meenu Walia, our another expert. She is a member of EROI, ISNO, ISBT, RSNA, and she did her. She's member of Anti-Ragging Committee, ex-secretary of Condemnation Committee, CRI, secretary guide in postgraduates in discipline of radiation oncology. Right now, she is in Manipal. Dr. Meenu Walia. Sorry, Dr. Meenu Gupta. And our expert is Dr. Sankalp Naidu. And Dr. Surbhi Gupta, she's professor and head of department, SN Medical College, Agra. She has got 40 publications to her credit. And right now she is heading the department. So they are our expert. And Dr. Swarupa Mitra, she is since on holidays, so she could not join us. So we'll discuss with all these. And second topic is on the surgical management of cancer cervix, and that talk will be delivered by Dr. Shahana Punnusetti, and our experts are Dr. Swati. She is Director, Gynec Cancer Surgeon, Laparoscopic and Robotic, Max Institute of Cancer Care, Max Super Specialty Hospital, Vaishali, Farkotganj. And she did her MBBS from SMS Medical College, Jaipur, DNB from Indraprasth Apollo Hospital, New Delhi, MNAMS, member of National Academy of Medical Sciences, and PG DMLS, Symbiosis Pune. So, and our next expert is Dr. Rupinder Shekhon. She is DGO-MD, PGI, FICOG, Chair Gynae Oncology, Artemis Cancer Center, Artemis Hospital, Delhi, NCR. She was past president, AOGIN, India, President AGOI, Association of Gynec Oncologists of India, Program Director, DNB Gynec Oncology, Program Director AGOI, Fellowship, Certificate Robotic Console Surgeon, Gynec Oncology, and so many Senior Consultant and Chief Gynec Oncology, Rajiv Gandhi Cancer Institute, Associate Professor of Obstetrics and Gynecology, Delhi University Faculty of Medical Sciences, AHRR, RGUMS, Bangalore. So we'll take first our speaker. We invite first speaker, Dr. Sankalp Naidu. He is Assistant Professor Radiation and Clinical Oncology, MNJ Cancer Hospital and RCC, Hyderabad. He did his MBBS from Karimnagar, MD Radiation Oncology from SRMS, CCEPC, Indian Association of Palliative Care in 2018. He is expert in palliative care as well. He did his DNV from New Delhi, FICO, and 1922. His area of interest is gynec malignancies, head and neck cancer, breast cancer, brain tumors. He has got many awards to his credit and so many publications. So now I invite Dr. Sankalp Naidu for his speech.
Thank you, sir.
Dr. Sankalp.
So thank you, sir. Thank you, sir, for your wise words, sir. I'm Dr.
You
Sankalp.
say about Surbhi?
Yeah.
Oh, yeah. Dr. Surbhi is also there.
Yeah.
Actually, Yes, I had already told. Dr. Survi is head of department SN Medical College, Agra. She has got 40 publication to her credit, and she is heading the department right now.
And she is interested in hyperfractionation of breast cancer and area of interest is cancer cervix also.
Yeah. So, Dr. Sankalp Naidu.
Yes. Thank you, sir. Hope everyone can see the screen.
Oh, yeah.
Yeah.
Okay. So, very good evening to one and all. I'm Dr. Sankalp Naidu, and I'm going to talk about role of radiation in carcinoma cervix. So, actually, carcinoma cervix is a very favorite subject of mine because it was my thesis also. I've treated, I was a part of treatment, and I've treated a lot of carcinoma cervix patients, and I have a special interest in especially IGABT, that is image guided adaptive brachytherapy in carcinoma cervix. So, coming to the role of radiation in carcinoma cervix, as I have 20 minutes, so I'll 20 to 25 minutes, I'll try to make it as crisp and clear. So I'll be dividing my topic into a basic statistics, a little bit of staging, role of radiation in carcinoma cervix, role of brachytherapy, and finally I'll summarize it. So, as sir has given a brief introduction in the start, we'll have to know what are the cancer facts of the world. So, what do we see? So, we see the latest Globocan statistics. So, right now, the latest is Globocan 2022, and 2025 is going to come in July. So, coming to carcinoma cervix in the world, so it ranks number 8 in terms of incidence, and in terms of mortality, it ranks number 9 in the world. Coming to here, you can see that large part of incidence, you can see that it is in the eighth position in terms of incidence. And when it comes to mortality, it comes in the ninth position. So coming to the areas where you can see over here with the arrow that India occupies this color shade of blue, which is approximately 15.9 to 24.6 persons per 1 lakh population. So, and whereas you can see in North America and the United States, you can see that it's a bare minimum. So, what is the difference is that the trend of difference is that the incidence is less because they have more screening procedures when compared to India. So this is the incidence perspective, and coming to the mortality perspective, here you can see again it comes in the bright red, approximately 8.8 to 16.8 per 1 lakh population. So as you can see that this green part coming to the incidence, this green part is in Asia. Asia occupies a big chunk in the number of new cases of carcinoma cervix, both in terms of incidence, mortality, and also the prevalence. So coming to India, so this what you have seen about the Globocan 2022, the world statistics coming to India. So in India, there is actually a boom of cancer cases in India, and right now, India is dubbed as the cancer capital and also the diabetes capital of the world. So we have a lot of new cases, and because of the population growth, it is reciprocating. The number of cancer cases is also reciprocating, increasing. So we have a lot of cases, and we have I mean, the number of deaths are also very high. So this part of India has been taken, and looking at the statistics, here I'll be specifically talking about carcinoma cervix. Here we can see that in India it is the second most common cancer, and when compared to both sexes, it is third most common. So I'll be showing it to you in saying that here it occupies the first common cancer in India among females is carcinoma breast, and the second is carcinoma uterus, carcinoma cervix. So when it comes to both the sexes, it is the third most common. So why is it so important? Is that the three most common which you'll have to see in India is carcinoma breast, head and neck cancer, and cervix. So which being said by the sir in the start that carcinoma cervix can be prevented. We'll see. We'll look into that in the future slides. So again, a small thing about cancer and carcinoma cervix. This is India. Why am I stressing more about it is that we have to know what are the most common cancers in India and what are the steps to be taken to prevent it or to screen it. So that the patient can avail early treatment. So that's the reason we'll have to know the statistics basically. Coming to the risk factors, a small slide on the risk factors. As we all know that HPV is the most common cause of cervical cancer. Also, like smoking and having multiple sexual partners, giving birth to three or more children. These lines are taken by Paris. So using birth control pills for a very long time also is one of the most common cause of cervical cancer. A small note on HPV notes. HPV is type 16 and 18, which are the most common cause of cancer, carcinoma cervix, and HPV infection. As we can see that a small note on this is what I wanted to give is that what happens basically when HPV, like human papilloma virus infection occurs. So here we can see that there is healthy cells which become abnormal cells. There is metaplasia, which actually our body's immune system is that it constantly becomes metaplasia and again it comes back to the original stage. But when we do screening in the pre-invasive part itself, before it becomes an invasive part, you can easily early the diagnosis, early the treatment, and better the prognosis is basically what we'll have to do. That is the reason screening is very important and must be done in India, especially because it is the second most common cause of deaths among females by cancer. Okay, a small note on the latest FIGO staging 2018. So as you can see that it is divided into 1 to 4 and individually it is also divided subdivided. So I'll be specifically talking about stage 1, which is confined to the cervix. As you can see that it is divided into 1A1 and 1A2. Here we can see that 1A1 is like having a stromal invasion of less than 3 mm in depth, and 1A2 is more than 3 mm and less than or equal to 5 mm in depth. Okay, one small point is that I would like to add is that I've taken this from ASCO website. Is this crayon over here? This will give you a rough idea of how much is 1 mm, how much is 2 mm, and how much is the nib part of the pencil is basically 1 mm, and 2 mm is basically of this. Fine. And the rubber part is 5 mm. This was specially given in the ASCO website. So coming to 1B, which is further divided into 1B1, 1B2, and 1B3, it tells us about whether the depth of stromal invasion. So here we can see that it is between more than 5 to less than or equal to 2 mm is 1B1, 1B2 is between 2 to 4 mm, and more than 4 is considered as 1B3. Coming to stage 2, it is further divided into 2A and 2B. One small note is that parametrial invasion is what we see. If there is longitudinal spread, it is 2A, and if it is a lateral spread and into the parametrium, you can see that it is 2B. Coming to 3. So 3 is divided into 3A, 3B, and 3C. And 3C is the latest one which has been changed. So 3C, when this actually given the prognosis of the carcinoma cervix. As you can see that 3A involves the lower one third of the vagina, and 3B is if there's any, if it involves the pelvic wall, or if it involves the kidney, or if there's ureter nephrosis. And 3C is any sort of nodal involvement. 3C1 is pelvic lymph nodal, and 3C2 is para-aortic lymph nodal. And coming to stage 4, which is divided into 4A and 4B. 4A is divided at which, if the cancer spreads to the adjacent organs, is considered as 4A, and if it spreads to the distant organs, is considered as 4B. So all this is very important because there is stage-wise treatment of cancer. So coming to the treatment by radiation. So RT plays an important role in the management of carcinoma cervix patients. So it can be delivered by a combination of EBRT, that is external beam radiotherapy, and brachytherapy. So basically, cervical cancer has two components, the central component and the peripheral component. The central component is confined to the cervix, vagina, and the parametrium, which is best treated by brachytherapy as a boost. And the peripheral component, which includes the lateral parameter and the regional lymph nodes, which is best treated by both EBRT and brachy. So brachytherapy is put exactly in the central component. Therefore, we can have a very good dose. We can literally ablate the tumor. So, external beam pelvic radiation is delivered before intracavitary insertion in patients with bulky cervical lesions, tumor beyond stage 2A to improve the geometry of the intracavitary application. Exophytically easily bleeding tumors and tumors with necrosis or infection and parametrial involvement. So, what are the indications of EBRT? So, indication can be given as a definitive in terms of adjuvant or in terms of palliative. So, indications of definitive, all the guidelines, all the indications have come from various papers which was done in the early 80s, 90s, and the early 2000s. So all these papers had a meta-analysis of all these papers, and we followed these papers, and based on that, a line and a plan of care has been delivered. So indications of definitive RT may be considered in stages 1A and even CIS. We can give for 1A1, we can give for brachytherapy alone, 1A2 or 1A1 with LVSI, intracavitary brachytherapy plus external beam radiotherapy. So coming to stage 1B to 2A, if patient deems inoperable or avoid surgery or RT preferred, ABRT and brachytherapy. Coming to stages 2B and to 4A, EBRT followed by brachytherapy, ICRT, along with concurrent chemoradiotherapy is the norm, which is followed worldwide. So, coming to the indications of post-op PBRT, any of the things which we follow is that more than one-third of the stromal invasion, LV space invasion, and large tumor more than 4 centimeters. So, indications of post-op CTRT is what we see is that positive pelvic nodes, microscopic or positive closed margins, or microscopic involvement of parametrium. So, is what which will be seeing that thing. The Sedley's criteria is what we see in the post-op exercise that what is the indications after radical hysterectomy, how to see whether we'll have to give RT or not. So if these are the four conditions, three things which we see: LV size, stromal invasion, and the tumor size. So this is the Sedley's criteria which is followed always. So what are the indications of palliative radiation, especially in stage 4B? For indications such as vaginal bleeding in terms of hemostatic RT, for pain, it clearly manages the pain, and sometimes if there's urethral obstruction also, RT, palliative RT of 30 in 10 or 8 in 1, 8 gray in 1 fraction is a very good thing. So coming to para-aortic lymph node irradiation, what are the indications? In radiologically or histologically positive para-aortic lymph node, prophylactically in patients with high risk of para-aortic lymph node involvement, patients with positive pelvic nodes disease and who's not receiving CTRT. So what are the evidences of that is RTOG 7920, in which they have taken bulky 1B to 2A and 2B disease. And finally, the result conclusion of the thing is that a higher percentage of local failure is salvaged long-term on pelvis plus para-aortic arm compared to the pelvic only arm. Therefore, especially in higher bulky tumors, and if there are common iliac nodes, so it has high propensity to go superiorly and affect the lower para-aortic lymph nodes. So that is the reason we have to make sure that in such cases, para-aortic can be given. So there was one more trial by the EORTC group. So it was telling a different thing altogether. So routine para-aortic RT is not indicated. They specifically said that you have to give it for disease more than more than 3C. So more than 3, stage 3 is what they have indicated in the latest update. So coming to the RTOG 9001, this was the trial which showed the advantage of CTRT, and it had a overall survival improvement. So based on this trial, which we have seen that the overall survival rate for patients treated with CTRT was significantly greater than for patients treated with ART. So 67 versus 41% at 8 years. This was a very long follow-up, and this was the study which showed the role of CTRT in the management of carcinoma cervix. So finally, I'll conclude with that. The analysis confirms the addition of 5FU and cisplatin, which now they have taken up a 5FU because of the additional added toxicity to radiotherapy significantly improves the survival rate of women with locally advanced cervical cancer without increasing the rate of late treatment side effects. So what are the different techniques which we give RT? So conventional 3D CRT, IMRT, and IGRT. So previously in the early 90s, 80s, where SIR was there, we used to have the conventional. During the conventional time, we never used to see a lot of tumor recurrences. But now, as the technology has advanced, we can decrease the side effects. But the only fallacy is that in the present, when compared to the previous and the present generation and era, we're seeing a lot of recurrences or tumor misses or recurrences outside the RT field. So, a small note on how EBRT is planned. So, a planning technique is basically positioning and immobilization, simulation, field design, beam energy, dose, and fractionation. So, coming to the positioning and immobilization, mainly supine position is followed, prone for different thing, which I'll be telling you in the next slide. So, we always use a knee rest so that the patient will be comfortably put in a supine position and the hands will be on the chest. So it is mostly preferred because it is most comparable and it can be reproducible on a daily basis. So prone belly button is mainly used in post-op cases and which you have this specific thing which is not available in all the places. But they use that especially because when in hysterectomy cases, the small bowel tends to come into the pelvic area. Therefore, you might be getting a lot of reactions. So coming to the immobilization, there are different types of immobilization which can use, and we use most commonly the cast, thermoplastic cast, and we also may have to see that it must be comfortable, reproducible, affordable, and minimum beam attenuation. So we use this thermoplastic cast because it is like simple. Supine positioning can be done with skin markings, which is cheap, reproducible, and ease of use, and it is very comfortable to the patient. This is a pelvic cast, 4 clamp cast. So also we need to know the need of contrast during simulation. In many places, including my center, which I am right now, when I was in private thing, we used to use contrast for all the patients. Now in high volume centers, as I'm working in a regional cancer center, so in view of the high volume of patients, it is impractical to give IV contrast. But the importance of IV contrast is that we can see literally the vessels are well delineated and we can literally see the small bowel or anything which is coming inside the field. So we do a X-ray simulation by a CT sim, and the patient is put in a supine position. The patient cast is put, and then proper bladder protocol is used, and we try to do a X-ray CT simulation. Then after this, coming to the 2D part, this was a border which right from our first year we used to see this border is that we have the EPPA fields. We have the superior border which is kept at the L4 L5 junction, and because it will putting at that junction will include both the external and the internal iliac lymph nodes. So if sometimes we'll be playing with the superior border in order to include the parietic field, which I'll be telling you in the next slide. So inferior border will be kept at the obturator foramen, and for vaginal involvement, if it is there, it is kept 3 centimeter below the lowermost extent of the disease. So actually, we put a vaginal marker and we try to simulate it, and that marker will be seen in the CT simulation film, and then we'll put 3 centimeter below it. And laterally, we'll go one to here we can see the pelvic brim. So 1.5 to 2 centimeter lateral to the pelvic rim will go for the lateral borders. Coming to the lateral field, here we can see the anterior margin. Both the superior and inferior are the same. The anterior margin over here we can see that it is in the anterior edge of the pubic symphysis. And the posterior margin is the S2 S3 junction. But nowadays, we are also seeing recurrences in the sacral hollow. So we are including the entire sacral hollow, and we are not following the S2 S3 junction right now. So in some places they still follow the standard, but in view of the present IMRT era, we are contouring it, and we are including the entire sacral hollow. So, coming to the shielding, so the entire box field must not be treated because there are some OARs and there are some side effects which can happen. Therefore, we try to shield the edges. Here you can see the colorful diagram of the different cervical lymph nodes over here, and we also see the CTV and the GTV. Okay, so that was in the AP view, and this is in the lateral view. This is the shielding which we try to shield with the OARs. Coming to the paravertic lymph node irritation, which I was mentioning earlier. It basically means extended fetality, which includes the pelvic and the paravertic lymph nodes, which must be treated as a extended field portal. As you can see, so this was the lower border, I mean, superior border of the previous field. But here we include the paravertic nodes because in cases where paravertic lymph nodes are positive, that is 3C2, we try to make sure that the superior border covers the renal hilum, often at E12 to L1 interspace. That is the only difference. So we have two field versus four field. So what is the like advantage of having a two field versus four field? So if the patient is very bulky, we tend to make sure that because of the properties of the X-ray photon, that it causes a hard glass appearance of the dose. So we try to give, if it is more than 20 centimeter of the abdominal margin, we try to give it by four field, or else two field is fine. So here we can literally see how the yellow, the blue, the pink lines are over here. These are the dose volumes, and here you can see that it is uniform in four field for a patient which is having a very large abdomen. Okay, so coming to the what are GTV, CTV, and ITVs which we give. So as we all know that GTV is a gross tumor volume which have to include it, and clinical target volume is a volume which is given as a margin all around the GTV, which includes the entire cervix, uterus, parametrium, and also the part of the vagina. And nowadays we are including ITV, the internal target volume. This is a new volume which many people are following nowadays. That this also accounts for the movement of all the organs during treatment and also the all the errors. So after trying a ITV, which will be including the entire part GTV, CTV, after trying the ITV, we'll give a PTV margin. Okay, so coming to the doses and fractionation. So what are the common doses which we use is that for the early stages, we go for 45 gray in 25 fractions at 1.8 gray per fractions, along with concurrent chemotherapy, followed by 3 fractions of brachytherapy. So for nowadays, it is a norm that 45 to 50.4 gray in 25 to 28 fractions is being followed, even both in primary radiotherapy and also in adjuvant. So paravertic, if there is a gross node, we boost up to 60 gray. Even if there is bulky parametrial tumor also present, we boost up to 60 gray. So the entire treatment gets only 50, and only the boost is more 10 gray is what we give. And coming to the paravertic, we try to make sure that we keep it at around 45 and not more than that. In gross nodes, we try to give a focused radiation, but 45 will be sufficing. Because the patient might develop lymphedema. So in palliative, you go for 30 grain. The most common thing which you use for hemostatic or for pain, which we see is 30 grain 10 fractions or 8 grain single fraction. So these are the recommendations, with the latest recommendations of intact cervix. What are the different OARs and what are the soft and hard constraints we'll have to maintain while we are giving radiation? Because nowadays we have come from the 2D era to the IGRT, the latest VMAT era, and we are in the targeted radiation. So we are trying to make sure that we taper the fields of treatment, and we give maximum dose to the tumor and minimum dose to the OAR. So this is a criteria. This is the criteria which will be followed for that was for intact cervix, and this is for the post-op cervix. These recommendations are for brachytherapy also. So how much must be the equity to, which I'll be discussing. A small note, there is a bivalent and Gardasil, which is Gardasil 4 and Gardasil 9, which is commonly used. Gardasil 4 and 9 is most commonly used, which is nonavalent and tetravalent. So which must be given. This is most commonly followed in the United States, USA, and it is being proposed in the next by the health minister that cervix vaccine are going to come in the immunization schedule in India. So a small note on as a paucity of time, I'll be telling about the importance of brachy. This is actually a separate topic. So IBS, I'm very interested in this topic, and I have delivered many papers on this. So IBS JKSTO guidelines, EBS recommendations for CT-based contouring in image-guided adaptive radiotherapy. So we had the previous history of Paris, Stockholm, Manchester, MD Anderson system. Now we had a crude way of treating carcinoma cervix at that time. Now it has been tapered. The principle is the same. The point A is what we have to see. Point A is the norm which the dose must be included within this point A. So previously we were in the ICR 38 era where we were doing X-ray based planning, brachy planning. We'll have to see the point A, point B, bladder dose. This was the bladder dose and this is the rectal point and the bladder point. So all these areas. Now we are in the CT guided area. So we are not just looking at the bladder point, we are looking at small parts of the bladder or the rectum, the 2cc part. That is very important, which has now come in the treatment era. So this is just here we can see that this is the area of treatment, and you can see that the treatment area, this entire part is being received, it is coming in the point A part. So whereas we can taper it down and narrow it down in CT-based planning. So dose to point A overestimates the dose covering the GTV. Smaller tumors receive higher dose, larger tumors receive suboptimal dose. This was the point which has decided to go beyond point A. So what was beyond point A is coming to CT guided, image guided brachytherapy is what we have come. So as we were contouring in the EBRT, so we are contouring in the brachy also. So this was the 2D to 3D transition in which IGABT, in which latest MRI and also CT guided, and also the latest ultrasound guided rectal guidance is being used. So why age IGABT? It was used to improve the local control and decrease the treatment related morbidity. So what is D2CC, which we always see, which we always try to see the total dose D2CC?
Dr.
In
Sankal,
Yes, sir.
can you conclude? Because
Yes, yes,
second
yes, yes,
speaker
in
is
one to
waiting.
one.
Okay.
So this D2CC is what we'll be seeing in the regular treatment paradigms. So we have the HRCTV and IRCTV, which is the high risk CTV and the intermediate risk CTV. So I would like to show a small thing is that these are the different ultrasound, MRI, and the CT based planning which is given. So I like to show a final thing is that we'll have to contour certain things. This is the latest things which we'll have to see that this is the advanced clinical diagram. When a patient comes over here, we'll have to make sure that we draw this diagram. For example, this is a diagram which was a part of when I joined over here. So this is how we'll have to do that at the time of EBRT and at the time of breaking. A small like a video regarding the importance of brachy is what I wanted to show over here is that we have the latest brachytherapy instruments by which we can do the treatments. So this is the latest Vanisi applicator, which I was a part of when I was treating in TMH. So this applicator, which we can treat all the different types of brachytherapy, which we all treat. So we have four options or environments. So this is the last slide, CT environment. We have the CT MRI environment, and we have the MRI and the CT scan environment. Also, finally, MRI environment. So this IGABT guidelines gives for each environment what to contour and what not to contour. This is the CT, this is the MRCT, and this is CT, MRI and CT, and finally we have the MR. So this is what is given in the latest IgA-BT categories, and which will be treating all the things. So finally, I would like to summarize is that radiotherapy is an important intervention in case of LACC, locally advanced carcinoma cervix. Image-guided adaptive brachytherapy is a major player in the field. Image guidance and more conformal EBRT treatment planning should be considered. Less treatment-related morbidity and nodal boosting is possible. And finally, CT-based planning is superior to conventional planning in terms of improving conformity of target coverage. So we'll have to correlate everything with the latest imaging available. Bring in with point A-based prescription and optimize to HRCTV. The rectovaginal reference points correlates with the vaginal stenosis and shortening. And the future is the vaginal and the urethra in the OAS. So finally, I say that early detection saves life. Thank you.
Thank you, Dr. Shankal. Since
Yes.
there is paucity of time, it's a nice depiction of everything.
No,
Radiotherapy, cancer cervix. Now, we'll discuss later on.
Yes.
Let us invite Dr. Shahana Punnisetti. She is MCH, Gynec Oncology, MS Obstetric in Gynae. She did her MCH from the CMC Vellore, Tamil Nadu, MS from the Bengaluru, and MBBS from Karnataka, Kalburji. She is right now consultant at Fatima Hospital, Gorakhpur. Earlier, she was working with CMC Vellore. She was assistant professor there, and then she came to this place. So now I invite Dr. Shahana Punnisetti. Dr. Shahana, are you there?
Yes, sir.
Okay,
Thank you,
you
sir.
can go
Thank
ahead
you for
with
your
it.
kind words.
Later
Yeah,
on,
good
we will
evening.
discuss.
Yes, yes. Good evening to all of you. And it was a well description by Dr. Sankalp Naidu. I will take it from there. So, why do we need surgery in carcinoma cervix? So, first of all, as we have seen, the trial by Landoni et al., which was done for early stage, showed no difference in disease-free survival or recurrence rate when patients were treated with radical radiation or radical hysterectomy. Recurrence rates were also similar. The advantage of having a primary surgery is it removes the primary disease and it provides with the proper surgical staging, which helps us in giving a tailored management to the patient. It avoids radiation mediated side effects, which are typically the radiation to the small bowel, large bowel, the vagina. Sexual dysfunction is underreported, but it is a problem for many patients because of the vaginal atrophy and the fibrosis. And ovarian conservation in premenopausal is usually desirable because ovaries are very essential for the bones as well as the heart. So there are certain principles of surgery. The important principles I'll be telling you here. Treatment of cervical cancer is stratified by stage. As we have seen, the staging has been revised from 2009 to 2018. The main important highlights, which we already discussed by Dr. Sankalp, the highlights are that is the stage 1A, the distance is the width is no longer needed. 1B is subdivided, and inclusion of nodes, especially the pelvic nodes and para-aortic nodes. The overall staging has led to upstaging of nearly 45% of the cases and downstaging of only 4% of the cases. This upstaging is a better thing. First, because earlier it was only a clinical staging, now it incorporates radiological as well into the, so that we get a proper staging through surgery, pathology, and radiology. So it leads to a better survival of the patient and also to the better treatment of the patient. So microinvasive disease, that is 1A1 with no LVSI, may be managed conservatively with conization or simple hysterectomy depending on the fertility desire of the women. So if you see the cone has got a specific criteria, it should be typically scalpel based, or even you can do it with a cautery. However, cauterization, that is charring, has to be avoided. The cone should be at least of 10 millimeter long and it can extend to 18 to 20 millimeter depending on the case, especially if it is adenocarcinoma where we would like to address the endocervix as well. And it should be followed by a endocervical curettage to see if there are any skip lesions. So, and it requires a tie knot at the position of 12 o'clock so that the pathologist is well aligned to the cone specimen. Now coming to fertility sparing surgery should needs a thorough counseling to the patient, and it needs a expertise for the same, providing the same. It should fulfill the conserve criteria. The conserve trial, which was a prospective trial, which showed that the recurrence rate was 2.5% with conservative surgeries, which included conization and simple hysterectomy with pelvic node assessment. So cone biopsy, the NCCN guidelines follows that the patients who are being provided with fertility sparing surgery should abide to the conserve criteria. The conserve criteria were cone biopsy with negative margins, absence of LVSI, histology typical of squamous cell carcinoma and adenocarcinoma, tumor size less than or equal to 2 centimeter, depth of invasion less than or equal to 10 millimeter, negative imaging for locoregional disease through a MRI, and the diagnosis has to be based on a cone, which is through the scalpel based or leaf based. The other fertility sparing surgery is radical trachelectomy. There are two options, either open surgery or vaginal surgery. These again, radical trachelectomy is a fertility sparing typically for a concealed women with squamous or adenocarcinoma histology. Tumor size is less than 2 centimeter. The fertility rates are pretty good with radical trachelectomy, and 70% of them carry through the term pregnancies. The most common abortions occur during the second trimester. Coming to non-fertility surgery, the standard of care is radical hysterectomy with bilateral pelvic lymphadenectomy or sentinel, wherever sentinel facilities are available. This includes stage 1A2, 1B1 and stage 1B2. The standard and recommended approach, that is the mode of surgery, has to be open surgery, as we all are aware of the LAC trial, that is laparoscopic approach for surgery in early cervical cancer. It was seen this was a prospective randomized trial which showed that the disease-free survival and overall survival was less when patients were operated through laparoscopy compared to open surgery. So the standard of care is open surgery. The lymph node addressal, there are different four level of lymph nodes which needs to be addressed. The parametrial nodes, the external iliac, common iliac, then the level infrarenal and suprarenal. So paratic lymphadenectomy for staging is typically done to the level of IMA. Recurrent or persistent disease in the central pelvis following radiation can be cured with pelvic exentration procedure. Pelvic exentration again requires a thorough counseling, and only selective cases are done through pelvic exentration, and it can be curative in such instances. In very select cases where there is documented evidence of persistent disease, that is especially central low volume disease is there, one can go ahead with radical hysterectomy with the intention of achieving a negative margin. So now, till 1974, it was Piver and Rutledge classification, which included the hysterectomies, and it was revised by Sir Dennis Curlow and C.P. Morrow classification, which is more precise, and it is applies to a 3D model of a uterus, where no longer we use the term as cardinal ligament or the uterosacral. We change the terms to paracervix or parametrium. Also, you can use paracervix, which is again classified as ventral, dorsal, and lateral. It provides more simple and unified terms so that it can be used across the world, and it is a standard nomenclature. The class is replaced by types, and it includes A to D. Level of lymphadenectomy is classified as 1, 2, 3, and 4. And it also conserves nerve preservation, which leads us to better patient post-operative outcomes. So just a small word on retroperitoneal spaces. Any surgery of CA cervix is incomplete without the development of these spaces. These spaces are potential spaces which helps us to develop the spaces and to approach the surgery, which gives us a better assessment of the parametrium. So if you see this division, paravesical and para spaces, these are the certain spaces which I'll not go into detail at this point of time. This spaces, the front one is paravesical space and the behind one is pararectal space. These spaces allows us to examination of a thorough examination of the parametrium. If we go back, the steps of radical hysterectomy include first opening the patient, that is either through a midline incision or a phalangeal incision according to our convenience. This is first step is to assess the parametrium, and that assessment requires the opening of these paravesical and pararectal spaces. So despite even if MRI and clinical examination suggestive of operability, when we open and if we see that the parametrium looks inoperable or involved, it is better to close the patient and send them for CCRT. So these are the parametrium. You can see that the ventral parametrium and the lateral parametrium and the dorsal parametrium. The ventral parametrium, it is defined as after surgical opening and development of two surgical spaces, the vesico-uterine and vesico-vaginal septum medially and the medial paravesical space laterally. I think my slides are not moving. The dorsal parametrium is a complex structure composed of the rectouterine and rectovaginal ligaments and the dorsal part of pelvic autonomic nerves. The term lateral parametrium refers to paracervix. Based on these criteria, they have classified as A to D with their own subdivisions. A is as good as saying it is an extrafacial hysterectomy, which involves removal of the ventral parametrium and dorsal up to 5 mm, and the lateral paracervix is cut at the just medial to the uterus, or just lateral to the uterus and medial to the ureter, and vaginal length is removed just less than 10 millimeters. This is indication for stage 1A, and it is as good as a type 1 hysterectomy or type A hysterectomy, simple hysterectomy. B is again subdivided into B1 and B2. B1 type B hysterectomy is similar to modified radical hysterectomy, where a little more of the parametrium on either side is resected. First, the ureter is unroofed, and it is at that level the lateral paracervix is resected, and the vaginal length is around 10 millimeters. Moving to B2 is when they combine the B1 surgery with lymphadenectomy. Type C1 is radical hysterectomy, or what we call it as Wertheim's hysterectomy. So this is similar, at the origin of the uterine, where the uterine artery originates from the internal iliac artery, the ligation is done at that level. And also the vaginal length is taken according to the adjustment with the tumor size. C1 is again subdivided into C1 and 2. One is preservation of autonomic nervous system, and the next is without preservation. Moving to D1, it is typically lateral extended hysterectomy. This is resection of the entire paracervix up to the level of pelvic side wall, together with hypogastric and obturator vessels, which exposes the root of sciatic nerve. D2 is D1 along with removal of facial and muscular structures. Very rarely done these days. Now moving on to level of lymph nodes, as mentioned, level 1 is external and internal iliac group. Level 2 is common iliac. Level 3 is aortic nodes below the level of origin of IMA. And level 4 is infrarenal, that is above, between the IMA and the renal vessels. So just a revision, this is A, B1, B2, C1, C2, and D. It is basically depending on the extent of resection which is provided in the cases. So the operative report should thoroughly describe the measurements of these parametrium, that is the dorsal, ventral, and the lateral paracervical attachments have to be measured and described in the operative report. Mode of uterine artery management should be described. The surgical length should be measured, including the vaginal length. Fertility preservation should be provided, and hemostasis measures should be mentioned. Coming to sentinel node should be provided only in those institutes which are well equipped with sentinel node management. Absence of staining on HNE requires a thorough ultra staging. Only then the sentinel node should be provided, and it is provided only for early stagings. So based on the recent NCCN guidelines for cervical cancer, if it is a stage 1A with absence of LVSI, for a woman who desires fertility, cone biopsy is sufficient. For women who has completed fertility, doesn't have a fertility desire, she can go ahead with simple hysterectomy. So coming to stage 1A to 1B1, as I said, any women who opts for a fertility sparing should follow the conserve criteria and can be provided with fertility sparing surgery plus pelvic lymph node assessment. So stage 1A1 and 1A2 with LVSI, cone biopsy, or depending on radical trachelectomy. Moving to non-fertility surgery, stage 1A, no LVSI, it is observed conized or type A hysterectomy. If the patient is unfit for surgery, in that cases, you can provide with brachytherapy or pelvic EBRT. Stage 1A with LVSI requires always presence of LVSI needs an assessment of pelvic lymph nodes. So anything 1A1 with LVSI and above requires pelvic node assessment. Moving to 1B1, 1B2, 2A1, it is typical standard type C1 or simply called as radical hysterectomy with pelvic lymph node assessment. 1B3 and 2A2, these are usually customized to the patient, depending especially if it is a very rare histology or it is an adenocarcinoma. Few surgeons prefer to operate and then provide a tailored adjuvant. The risk of having a postoperative adjuvant is higher in these 1B3 and stage 2A2. So it is a surgeon call to decide whether they'll send for CCRT or for surgery followed by CCRT. So this is the simple hysterectomy, just a difference which comparative analysis between the three types of hysterectomies. So this was a radical hysterectomy specimen. Now coming to exentration, it is usually provided for recurrence cases. The exentration can be anterior, posterior and total depending on the cases. Exentration are curative when done well. The success rate is around 50% with a mortality of 5%. So this requires a thorough counseling. Anything, the terrible triad syndrome, which is famous, there is pelvic side involvement, there is presence of lymphedema, sciatic pain and hydroureteronephrosis. These are the contraindications for exenteration. So it again prerequisites are good performance status, MRI pelvis and a PET CT to rule out or any other metastasis and thoroughly informed consent regarding the mortality as well. So as I said, it can be anterior, posterior and total depending on the elevator ani, whether it is supraelevator and infralevator. So the takeaway is FIGO as per the FIGO 2018 stage, the operability is for stage 1A1, 1B2 is the standard radical hysterectomy with pelvic lymph node dissection. For 1B3 to 2A1, it is customized to the patient as high risk of having a adjuvant radiation. Lymph node assessment is very essential. Open approach is the standard of care at present. Fertility sparing surgery needs expertise and consent as is only for certain histologies. When it comes to neuroendocrine or gastric or HPV non-associated tumors, it is not advisable for a fertility sparing surgery. Thank you.
Thank you, Dr. Suhana Punnashetty. Now, we'll take few comments from Dr. Rupinder Sekhon regarding surgical management. Dr. Rupinder Sekhon. This President
that was a very good presentation. And like very rightly said, doing a proper radical hysterectomy in a CA cervix patient requires maximum expertise. That is one of the most difficult things that even gynecologists are able to do. Basically because, one is not able to take the full parametrum like it should be done. And ultimately patient, if not done properly, then that patient lands up with a dual modality of treatment. That is both surgery as well as radiotherapy. So that is one thing. Secondly, it is very important to choose your patient carefully. Anything beyond 1B2, that means anything beyond a 4 centimeter growth or a 2 centimeters growth should only be addressed by a expert, and that also after you have completely assessed for lymph nodes. So these days imaging is considered part of the staging process. So it is very important to do at least an MRI of the pelvis, if not more. And if you find anything suspicious, maybe you should include the upper abdomen as well. Where it is available, one can also use the PET scan to assess the nodes and also to be able to assess the extent of disease, if at all. MRI gives you a very good idea of the extent of the growth, how much of any myometal, any extent stromal invasion and all that is there. That having said that, when we take the initial biopsy for cervical cancer, it is nice if we can get a report on the LVSI as well, because if the LVSI is positive, perhaps you want to reassess the nodes and perhaps you do not want to do surgery, and it might be wiser to give that patient radiotherapy. Rest, I think, has been very beautifully covered. I don't think I need to add anything more to that.
Thank you so much, Dr. Rupinder.
Yeah.
Thank you so much. And few comments from Dr. Swasti.
Yeah, it was an excellent presentation. So I think very rightly said by Dr. Rupinder that, surgical, resection of the parametrectomy is the real key, and having a negative margin is the real key. We should avoid dual modality treatments in carcinoma cervix, and very careful selection of our cases based on a comprehensive clinical and radiological examination is very important. So I think that's a real good meet. We had very nice inputs from surgical domains and classification.
That's why we have started this type of thing.
Both the
Yes.
Yeah. Now I invite Dr. Survi for her comments on the radiation oncology. Dr. Survi.
She is having cold coryza.
अच्छा,
No, but
चलिए
I can hear a voice.
Dr. Meenu Gupta, are you there? From
Yeah,
Regal, I
I'm
think.
good.
Yeah, yeah.
Thank you. Thank you. Actually, it was a very nice effort from Chaturvedi Center and very nice to gather, especially in these cold days, and to share the academics. Thanks both the speakers, and very well covered all the topics by Dr. Sankalp, including the vaccination.
Yeah.
Including the vaccination schedule and all that. I just wanted to add one thing, like because we were discussing about the HPV vaccination, and Sikkim is the first state actually. They have vaccinated all the school going girls, and maybe the population is less in that state. But Sikkim is a role model, and I remember last year where our Honorable Finance Minister, once they declared the budget, and they also told about the availability of these vaccinations in the government centers for just rupees, I think 320 rupees. And expert gynecologists, they can tell if that has been added to the national immunization program. That was in the last year.
No,
So this is, uh,
that has
yes,
happened
madam.
only in BR. It
Okay,
has
okay.
happened only
So
in BR and rest
this
other
is the one.
places.
Yeah, this is the one area actually we have to do lot of the screening camps, because still we are not in a very developed country, or not our country at present is the resource limited. It is in between. And if we see, there are the ESCO guidelines for the screening guideline for the resource limited, and in between the sources and mid resources, where they actually recommended every 10-year screening programs, and that is different. But we have to also, it was very nice, Dr. Sankal Patil, you touched this area also. And next, I am moving towards the surgical part, fertility sparing. Definitely, because of the awareness in our clinics, also we are getting some young ladies, and those were the times 3 or 4 decades earlier, where the people were coming in the more advanced with VVF and all that. There are some selected cases, young girls, young married, where we can go for the fertility sparing, and that has to be done by the expert hands. This is very important. And as far as the prophylactic paraiotic nodal radiation, this is another area. If Dr. Sankalp is agree with me, so at
Yes, ma'am.
least there are some papers published where in the
Pro-para.
nuclear one go up to the L3 upper border, where L3 upper border is covering at least 60% of the your nodes. So it is a routine. I mean, there is a individual practice also. My practice is also, if the patient is coming to me, because if you have the art of treatment with the IMRT or IGRT, where you can spare the kidneys and all that, so you can go up to the L3 level. This is one area. And image guided brachytherapy, definitely. If we are talking about the brachytherapy, point A is no, the image guided, because the anatomy is different, volumetric analysis patient to patient varies, and we are getting very good results of this. One trial I just wanted to mention, the role of neoadjuvant, or there are the interlaced trial which was published. It is a randomized phase 3 trial where the locally advanced cases of the CA cervix, there is the short course of chemotherapy. This is not widely practiced, but 32 countries, including India, was in this trial, where weekly carboplatin and taxanes were given for the 6 weeks. Weekly treatment, that was the short course of chemotherapy, followed by the chemoradiotherapy. And they are giving the result that the death risk is increased by 35%, or the progression-free survival is better with the better hazard ratio, but that is not in the guidelines. This is, I am discussing the phase 3 trial, because we are catering patient with the locally advanced diseases. They are coming, and this is one area where we can give the short course weekly chemotherapy. And I think it is very well covered all the topics. I wanted to recommend one more for the recurrence salvage surgery is also there, but sometimes central recurrence is there. We have the modalities like SPRT. In some of my patients, I tried SPRT to the local recurrence, and still more data is actually required for the more years to come up with this data. The areas where patients are coming with the VVF, and we are still catering, but sometimes we are lacking experts for the pelvic exenteration actually, where the facilities are available. Our surgical colleagues are there, and these are the where we can give the better quality of life also, because the ladies with the VVF and rectovaginal fistulas, so the quality of life can be better if with the exenteration and all that, but we have to motivate all these facilities also. Thank you.
Sir, I'm audible
Thank you.
to you? Hello.
Yeah.
Yeah.
No,
Sir, I could
Most
not
welcome.
connect.
You're
Yes.
welcome.
Yeah, everything is well covered by Dr. Sankar. Just want to one comment that for lower third of the vaginal environment, that is for stage 3A, we should cover also the inguinofemoral node. We should not ignore this.
Yeah.
No,
Yeah.
this is the one
Definitely.
comment. And the second thing is for the endocervical growth. I think surgery is the better modality, even for the early stage. This is the second thing. And the third thing is whatever Dr. Meenu has told that neogen chemotherapy. I have the personal experience for stage 4A. We have given neogen chemotherapy up to 4 to 6 cycles. This patient is very well down stage, and this patient also can be considered for the either the hysterectomy or the concurrent CTRT. So we should not forget the role of the neogen chemotherapy in the locally advanced cancer also. That's all.
That's
Otherwise,
very
everything
true.
is well covered.
Very true. Dr. Ayush, are you there? Dr. Ayush? I want to comment on one 2cc dictum, which Dr. Sankal has mentioned. That's very important because most of the reactions in brachytherapy, they come either in the bladder or in the anterior rectal wall. So later on, they come with the bleeding per urethra or bleeding PR. That can be avoided by using proper dose and distribution. So it is really well covered and very nice webinar, and we have covered almost surgical.
Dr.
Thank you.
Sankar, I just wanted to add one thing. Apart
Yes,
from
ma'am.
discussing all those guidelines, what we are doing actually on the TPS and all that for the young doctors and students, it is very important for the plan analysis with our
Yeah.
discussion with the RSO and final analysis, and we have to design all those isodose lines and all that, and that is actually very important in my personal experience also. And we have to actually check all those points, analysis, discussion with the RSO if there are any hotspots are
Now,
there. So this for the young students, and
Yes.
that is very important.
Actually, I've kept that part, ma'am. Plan evaluation, plan and how a physicist plans any plan, how we do a contouring. That was actually taking more 40 slides, and during due to the paucity of time, I was not able to. I just hit the slides. I
that's
hit them like else I would have
Yeah,
completed that also.
I
Yes.
agree. And for the students, I always ask them to, you have to spend time with your RSO, and
Yes,
before
ma'am.
giving the final plan, that is in routine practice, that is actually very important.
Yes, ma'am.
Radiotherapy is difficult in planning and dosing. That nobody
actually
can.
we will
That's
include certain physicists also, and
yeah,
we'll have some webinar on exclusively on dose
dosing
and
and
the planning system.
system.
Yes, ma'am.
Okay, so we'll have some radiation oncologist only in that group, and we will start with that so that the people may know how to do and what to do, what we should avoid
That's
and how
right.
it should be done. Yeah? And this is very nice,
Take
Dr.
home
Sankalp,
message.
and
Yes, ma'am.
yeah,
Noted, ma'am.
as you have already explained everything, because short time is very short. So thank you very much, Dr. Sankalp and Dr. Punya Shetty, and all the Specialist, a special
Take home
comment from Dr.
message.
Swasti.
One, I'm a gynecologist, so I can comment. The take home message is early stage, 0 stage,
Go for
and 1
surgery.
stage. Only those are actually meant for surgery. And in that, do the lymph node assessment and the area extent and all those things. And just like Punesh Shetty has said, it is the histopath and the CT scan or MRI, radiology part, that will decide the further line of action. So, and the rest, like what we get, surgery is not needed. Chemo radiation is sufficient. That doctor will only tell.
That's right. In the early stages, actually, surgical and radiotherapeutical results are equal almost. So it depends upon the patients. In stage 1A, 1B, it depends upon patient's choice what he wants. Some people, they say go for surgery only. But later on, we have to cover all those things as per the staging of the patient, and after getting the sample, after histopathological status of the patient, we decide accordingly. So thank you, everyone. Thank you so much for joining us.
Thank you, sir.
Thank you. Next time we'll meet with
Thanks.
some different topic.
Thank you, sir.
Again, we'll see all of you. And the
Thank you.
same expert panel will be there with us. So thank you, Clarinet team, for your seamless support. And thanks all for great participation. Yes, there's one question left unanswered. Still, did you see in the chat box?
Recommendations on role and type of cervical cyclist.
Cerclage after trachelectomy. This my gynecologist friends will answer. Ma'am is there? Swati is there? Swati, Dr. Swasti, and Dr. Rupinder. So after trachelectomy, you can't go for cerclage. Trachelectomy is done for the stage 1B or more. Otherwise, it is LEEP and conization. So if you go for cerclage, of course, it will be difficult and premature. Preterm birth is a possibility in young patients who want fertility. So that's what I would like to answer. So thanks all of you. Thanks once again.
Thank
So
you.
good night and we take your leave. Okay, bye-bye.
Thank you, ma'am. Thank you so much, everyone. Good night to all of you.
Thanks, sir.